Can see that well?
Yep.
All right. Welcome, everybody, to today's webinar, Street Medicine, a Critical Pathway for Behavioral Health in California. I'm so happy that you came. I've been dreaming about a webinar like this for many, many years because when I started street medicine, there were only two street psychiatrists that I knew of. One, Eileen Riley in Boston, and Liz Fry in Atlanta. And now there's so much more street medicine and so much more street psychiatry that we can actually begin to think about how to build a system starting from the street backwards. I'm joined today by uh, my esteemed co-presenters, Dr. Lisa Wong, Director of LA County Department of Mental Health, Dr. Timothy Ibrahim, Lead Physician of the Inland Empire Healthcare and Action Team, Dr. Shai Robb, Chief of Psychiatry for Countywide Engagement and Field-Based Services in LA County Department of Mental Health, Dr. Caitlin Schwan, Associate Professor of Family Medicine and Director of California Street Medicine Collaborative, and Kelly Bruno. Although I see you're a DSW, so you're Dr. Bruno-Nelson as well. Executive Director for Medi-Cal and CalAIM for CalOptima. And before we get any further, I wanted to just lay the groundwork on why we're here today before I pass it off to the rest of the panel. And first, defining our terms so we're all on the same page. So, street medicine is healthcare delivered for people experiencing unsheltered homelessness in their lived environment. And if you want to bill for this, you can bill Place of Service Code 27. It's also important to know the term field medicine, which is healthcare delivered to people experiencing homelessness, sheltered or unsheltered, in any non-traditional brick and mortar site. So it's inclusive of street medicine, but also includes mobile medicine, homeless shelters, and temporary lodging. For purposes of this webinar, we're focusing on street medicine because that's the primary way that people experiencing unsheltered homelessness will receive care. The emphasis on unsheltered homelessness is because uh, one, over 70% of people experiencing homelessness are unsheltered in California. And two, 50% have trimorbidity, physical health disorders, mental health disorders, and substance use disorders, compared to only 2% of the sheltered homeless population. And despite them having this high level of trimorbidity, they lack access to care. In Los Angeles, 75% have insurance, but only 7% are able to access primary care, and only 3% were offered behavioral health services. Historically, street medicine has addressed this by going to the people and delivering a very high level of care on the street, which includes treatment for mental health and substance use disorders, which for us is just part of primary care. In the landscape analysis, over 70% did diagnosis and treatment of mental health, and over 60% did MAT, medication assisted therapy for treatment for opioid use disorder, which at the time blew my mind how high that number was. And since then, the biggest strides that we've made have been in street behavioral health care. So on the right is Dr. Coley King, primary care physician in Venice, who really pushed us in primary care to practice at the top of our scope for behavioral health. And then, of course, Shai on the left, who really made street psychiatry accessible to people in LA and has been a model nationally. And as we're thinking about the webinar, I know we have people from all over the country, but this is a California webinar, and I wanted to frame what the system looks like in California. So it's siloed and separated. Mild to moderate disorders are people responsible for them are primary care and non-county psychiatry, which you'll hear termed community psychiatry. This is defined by a diagnosis, which includes schizophrenia and bipolar disorder. It's paid for by the health plans. SMI, serious mental illness, belongs to the county's responsibility. This is defined as a diagnosis plus severe and persistent plus functional impairment. And if you have those, that equals county mental health specialty services. So it's a specific set of services that the county offers. It's paid for by the county under the Behavioral Health Service Act of BHSA. One of the reasons why we're here today, why now, is because the BHSA includes a new field-based substance use disorder FSP. And Dr. Wong will explain what that is, but it's part of the impetus of why now. And the take-home message of the slide is SMI is not a diagnosis, but it's a severity requiring a higher level of service. And to frame how we all need to work together, and there's plenty of room for all of us, I created this pyramid. I went out, I asked primary care, street medicine, psychiatry, street medicine, what percentage of the population, just their gestalt or the people they see, would fall into these categories. There's some variation, but about 10% said no behavioral health needs, 70% or more felt could be well controlled with street medicine, primary care, and community psychiatry. Then at the very top of the pyramid, it was like 5%. Some people even said 1% that might need to be conserved or would be eligible for care courts in California. And it's this 15% or so that where the biggest gap is. People that would require a street medicine type of FSP, and that's where street medicine and our county behavioral health can partner so well. And so with that, I'll pass it on to Tim.
Amazing. Thank you so much, Brett. And to Caitlin and the crew here, it's really remarkable to be kind of sharing a space with you all. And let me go ahead and get started here. So I'm gonna introduce myself as I'm getting my slides up here. I'm Tim Ibrahim. I am the lead physician for our Inland Empire region for Healthcare in Action. I have about 15 minutes to tell you a little bit about our model, and kind of how we operate towards exactly what Brett was sort of talking about, which is serving as low barrier care for our unhoused neighbors here in the Inland Empire. And then I'll tell you more about our kind of organization at large and sort of where we're operational. Um, let me, I just want to make sure my slides are actually up and that you can see them. Okay. I'm going to start like this. I think might be the best way. Is it okay? Can you guys see?
We can, but it's in kind of that funny format from before, Tim.
Okay. How about now?
Yes, perfect. Thank you.
Okay, awesome. Okay, so this is HIA Unpacked, and I have a little quote here, and some of you may be familiar with a colleague of mine who I'm lucky to share. And I know this maybe doesn't come from him directly, but he gets to say it all the time, and I copy him, which is that the streets build the team. This is from Eddie Minacho. And so I hopefully get to prove that to you is that the approach that we've taken in the street medicine space is such that the needs of our population sort of dictate how we operate and have sort of start to build a system that works for them. So again, Tim Ibrahim, my background is in emergency medicine and in addiction medicine. And so as we move forward and you hear me speak about behavioral health, I think on the one hand, you should know I am not an expert in behavioral health by training. But if a lowly ER doc could do it, I think it means that there is room for us to build in behavioral health into an integrated healthcare setting that includes primary care, addiction medicine, and psychiatric care as well. So I don't have any financial disclosures, and this is about the healthcare in action model. It's really about sustainable street medicine. That is the goal. And some images to share here. But when I say this, what I mean is, and Brett, you alluded to this a little bit, is that street medicine is coming into its own, and part of that means that it requires we have a pathway forward, because in order for us to be successful at gaining the trust of the population that we serve, we need consistency, right? And part of consistency is reliability, and part of reliability is sustainability. And so, this is what our model sort of looks like, just broad strokes. Is we have two major components of how we operate, really that's split into three. Clinical care services, which kind of looks like the composite of primary care, mental health care, and substance use disorder care, just to name a few of those aspects. And then term of wraparound services, or what you might be familiar with as CalAIM services, like enhanced care management and community supports. This is what our team structure sort of looks like. And I think you'll find that street medicine teams share similar structure, but this is what how we currently operate. I'm going to start here towards the middle bottom, is at the center of our on the ground team is an APP, an advanced practice provider, like a nurse practitioner or physician assistant. And that person functions as the main provider for that patient. So they are their primary care provider in many ways, right? They're going to manage several aspects of their health, and they are in direct communication with what's happening with social services. So that's happening over here. And so our main, um, personnel that's dedicated towards the key services that we offer, in addition to clinical services, enhanced care management, alphabet soup, and community support services. CalAIM services are peer navigators, or CalAIM navigators. And we have maybe roughly 8 per each of these teams. Each of those carry a panel of patients, folks that they have outreach to, that we've enrolled in our services. And those panels change from, time to time, month to month. But overall, that is how our clinical panel is sort of being constructed. And it's through that funnel of outreach into our services that the clinician, the clinical provider, is able to see those patients and then be supported by what we call a clinical support partner, which is our beloved term for the many hats worn by a sort of medical assistant or EMT trained individual who can help structure the schedule, navigate the vehicle, and we'll get to the vehicle in a second, um, stock and vitals, and then performing things like phlebotomy and medication administration. And so many times the answer to the question of how do you do X or Y, it's we the clinical support partner. And so they're an essential portion. So this is the trio, the triad, that essentially is on the team at any one time that's in the field. And so each teamlet cares for approximately about 200 patients, and that's plus or minus. And I sit in this position. I get to supervise the teams both directly and indirectly, from both a clinical perspective and then some of the other operational pieces as well. We have a consulting psychiatrist, and I really want to highlight this particular aspect is in what we do in managing mental health disorders. I think one of the key um, things that comes up is, well, when you're beyond the management of mild to moderate mental health disorders, and you're in the realm that some might identify as SMI, or but at the very least as a severe mental illness, or maybe an uncontrolled schizophrenia or bipolar disorder, getting support from a psychiatrist is essential. That said, having that person either indirectly available or directly available, I think we have a consulting psychiatrist who hosts psych rounds for us, and that we're able to present those cases to him, and we'll get that feedback. He's also able to evaluate patients in the field or via telehealth with us, and that also can support us as well. Um, this is a cross section of some of the pieces that we were able to tackle from where we sit in street medicine, both coming from chronic disease management, and then in sort of tackling psychiatric illnesses and substance use disorders as well. And I don't think this is much different from what you're going to see across many street medicine services, right? Um, a lot of questions come up with where and how and who, and so this slide kind of gets into that a little bit. And so, how do we operate? Well, we do have contracts with particular municipalities. We have ongoing contracts with health plans, both in the CalAIM space and the clinical space. And so, here are some of the target locations where we're at. We're currently operational in 6 counties. And we are expanding. And so this is certainly a space for expansion, and there's so much need. There's way more than any one group can really tackle. And so there's such an importance of expansion of street medicine services. Here's a bit of just kind of like a quick lay of the land in terms of our breadth of care. In the last year, 2025, we had over 18,000 clinical visits. We had over 88,000 CalAIM related visits, so services like enhanced care management, community supports. And so, in broad strokes, that's patient navigation services and housing navigation services. And we served over 6,000 unique patients over the last year. Um, I have here some pictures to share that might encapsulate just in broad strokes how we operate. We'll have a morning huddle. We'll communicate about the patients that we're going to be seeing that day and how we're going to be seeing them, and in sort of what order we'll load the van. And this is what our vehicle looks like. We have various vehicles, as you can see on the far right. In some cases where we need to access terrain, like we do in the Inland Empire and reaching the riverbed regions, we're operational in like four-wheel drive suburban, or in some cases, like you said, the typical Sprinter van, custom setup with just a medically capable van. We're on the move usually early in the morning, and this comes back to the initial aspects of just street medicine as a whole. We'll take a servant's pose, and we're sort of meeting the patient at eye level or below, to hear about what's going on. We interact with the patient's emotional support animals and their pets, and I think that helps to tie us into the family. We access different parts of our counties that we serve, and we might be hiking terrain, and sometimes accessing folks who really are not interested in being seen, right? And not interested in being out in the open. We do field phlebotomy services. And we're able to access lab services, with our partner labs. We pay attention to what our patients have to say, and we sort of access a different part of our clinical brains in working through sort of evidence-based practices that allow patients to sort of take on the role of the patient, where we're the consultant and really not mixing those roles up. Um, Get to appreciate art and take a break sometimes. Sometimes when we get to visit a new home, when somebody gets housed, and us having been a part of that, we get to visit them and do a housewarming in some cases, right? And performing wound care, big aspect of what we do. Um, Got to do charts, got to do documentation, and doing so is a portion of our day, and debriefing and hearing from the team about what went well, what didn't, how we can grow, and also kind of case conferencing our patients. We get to be a part of really major aspects of people's lives, a new pet, a devastating diagnosis, a wedding, a new birth, ID, and sometimes death. And that's a part of our roles for these patients, right? Sometimes we find ourselves in critical scenarios or in really tough aspects of folks' lives, and these are sort of the qualities that we use to move forward: empathy, humility, receptiveness, and authenticity. I wanted to share a case that I think might encapsulate how we're able to operate and move the buck forward in the behavioral health realm. This is a gentleman who's consented. His name is Ray. And his story starts with a history of abuse from his parents at a young age. He started getting services at age 15. He was diagnosed with schizoaffective disorder at age 22. He stopped medication after a year and 10 years later attempted suicide. We got the referral from a homelessness outreach partner called SWAG, because he had a partial foot amputation from a skin infection. He had some visual and auditory hallucinations. His insurance was a barrier, but we were able to assist him with dually enrolling, started him in some oral antipsychotics, and then transitioned him to a long-acting injectable. He's now on his 32nd dose of that injectable. He's doing very, very well. He's continuously enrolled in our services, and he's currently housed in mental health specialty housing and doing very well, running a bike repair service on the side. And substance use care is also a big aspect to what we do, and near and dear to my heart, as an addiction specialist. We do care for a lot of folks with opioid use disorder, and here's one. This is not, of course, her actual image, but she goes by Rhonda. She has opioid use disorder, and basically found the need and was highly motivated to get into care because of the loss of both her husband and her son, who died of fentanyl overdoses. We attempted microdose induction. That was met with lots of barriers. We attempted a macrodose induction, giving more buprenorphine all at once, and she had precipitated withdrawal, and we thought we were going to lose her forever. But then reality is that our patients are just amazing, and are so perseverant. And now she's, in methadone treatment. She has her ID, and she's actually tentatively housed. She works as a housing manager now, and she's doing exceptionally well. And I share some of the comments she shared with us. But lessons learned is that consistency, investment in your patient, leveraging your patient's resilience, acknowledging the challenge and radicalizing hope, and fireproofing the bridge. And this is what I'll leave you with, which is a lot of times that our patients get the sense that they might burn a bridge, another one. And what I always tell my patients is our bridge is fireproof. You can't burn this bridge, and we can't burn it either. We'll be there always for you, right? And so I think it's encapsulated in a lot of the messages we've learned. I'll pass it on now to Dr. Shai Rob, and I'll let him introduce himself.
Thank you so much. I will take it from here. Let me quickly share my screen. Give me a thumbs up if everything is looking good. Perfect. All right. Hey, everyone. It is an honor to be here. I am Shai Rab. My first name is Shayan, but everyone calls me Shai. I'm the new Chief of Psychiatry for the Department of Mental Health, specifically over countywide engagement and field-based services. The experience that I've kind of had with the county is I was the first full-time street psychiatrist hired by the Department of Mental Health in LA County. And really kind of, when I first came to the streets, I Googled street psychiatry and there were zero hits, really. There wasn't much guidance on how to provide the service, what medications I should use, how I should stabilize someone, what the role of a psychiatrist is, how do I integrate services across the county, how do I take someone who is severely mentally ill with co-occurring medical problems, substance use, severe schizophrenia, poor insight into their mental health condition and transform their life and reintegrate them into the community. I had no idea, but like the previous slide said, the streets will show you what you need to do. That's really what happened with me and my journey in DMH, and now I have the privilege of being over here and sharing some of the stuff that we've done. What I'm going to do is kind of complement what Tim just talked about, and where kind of street medicine might, the outer limits of what street medicine can do, that's where sometimes street psychiatry takes over for a really complicated behavioral health recovery. And that's what I'm going to talk about, where specialty mental health kicks in and what we bring to the table. So the first thing is, what's the team structure like for any specialist field-based mental health team that is providing specialty mental health services? It's a multidisciplinary team. You have community health workers, you have social workers, you have substance use counselors. This is our non-medical kind of arm, but we have a medical arm which has more psychiatrists and nurses available. Now, the psychiatrists on these teams are not present on a consulting basis. They are full-time psychiatrists who are the lead physicians for these teams and really bring that subject matter expertise in the behavioral health space to the table. What can a team like this do? A team like this can provide outreach services. A team like this can provide case management, access to shelters, mental health triage. Now, this is what a lot of general outreach teams can do as well. But when you add this medical arm of psychiatry and nursing, now you can offer a combination of psychiatric and medical services, which means you can provide nursing assessment and support, psychiatric treatment and support, laboratory workup, consultation with other subspecialties. And here is the important part that the specialty mental health team brings to the table. You can get access to psychiatric residential placement. You can get access to inpatient psychiatric care, inpatient and emergency psychiatric care coordination. You can even get coordination with jail and mental health related care coordination as well. So the larger ecosystem of services for more complex cases starts opening up when specialty mental health services come to the table. Now, the specialty mental health services have been available in DMH for quite some time. There was a metamorphosis, though, when DMH began building up its street psychiatry infrastructure. I want to focus on that next. What is street psychiatry? Street psychiatry is a form of street medicine, but it's a specialized form that focuses specifically on mental health conditions. But it's still, being medically driven can integrate with the larger medical system and provides mental health services in collaboration with physical health care. But it's nothing magical. Street psychiatry is essentially regular psychiatry that's been adapted for people who are not living in traditional settings, essentially people who are living in environments that are not intended for human habitation. This could be cars, this could be the streets, this could be bus stops, this could be abandoned buildings. When you're practicing psychiatry in these types of settings, you can't use the traditional approach to psychiatry. You need something different. You need a different set of medications. You need a different set of rules for how you're going to work with people who are in these non-traditional environments. Our medications have a lot of side effects. You have to keep these in mind when you're treating people within the reality of their living conditions. What are some goals of street psychiatry? It might be very simple to state, but when I first show up to evaluate someone on the street, I'm not trying to find out when's the list of their psychiatric diagnoses. I'm not trying to find out how many times they've been psychiatrically hospitalized. I'm trying to be a human being so I can connect with this person and build a doctor-patient relationship so they trust me. That's the most important part, where I want to be a human first and a provider second, and really get to kind of overcome some of the trauma they might have experienced at the hands of psychiatry. Remember, as psychiatrists, we put people in involuntary hospitalizations. We give people injections against their will. We've taken their rights away. Psychiatry doesn't have the best street cred. So I do have to spend some time building a strong doctor-patient relationship and developing as much of a shared understanding of their mental health needs as I can. And then after that, I still don't turn to diagnoses and medications. I turn to addressing their basic needs, their personal safety, and any necessary medical care that they might need, activating all benefits. And then finally, when the individual is ready to take that journey with me, starting psychiatric treatment and starting the rehabilitation process. And rehabilitation over here is, my medications will not magically make someone transform their life. My psychiatric treatment might put someone in a more regulated emotional state, a more regulated mental state where they can accept lifestyle modifications with us. They can make those lifestyle modifications with us and try and transform their lives out of homelessness. At the same time, a street psychiatrist is well positioned to integrate system-wide interventions and resources. This is something specifically that a specialty mental health provider can do. DMH is one of the largest mental health providers in the nation. And we can tap into those resources and bring them to the table to create a truly transformative plan that integrates all levels of care. Because that's what our folks need. Is they're so deep into their self-neglect that they might not even realize the help that they need. So we need to activate a lot of resources to transform their life. Now, I'm going to pivot into talking about a very special team in DMH. All of our programs are very special, but there's one particular program that I kind of began working with, which changed my life, and that's the home team. Why is the home team important for this particular discussion? First of all, HOME stands for Homeless Outreach and Mobile Engagement. The home team was the first team where street psychiatry was truly integrated with specialty field-based mental health services. The workflows that we built were built completely with the team and our client within the reality of their living conditions. There were no parameters for this. We had to build it from scratch, and we let our clients and the system teach us how we needed to build this. Take a look at the patient population being served that home team was charged to serve with. So, this team was supposed to serve unhoused individuals with severe mental illness who are challenging to engage, who are not providing for their basic needs, who are lacking insight into their mental illness, who are failing to benefit from traditional mental health services and less intensive services, have co-occurring substance use and physical health needs, and are on the brink of hospitalization. How do you help someone who is this impaired? Who is responsible for this individual? Historically, it's been hospitals. It's been hospitals where these folks would go, but we know that sometimes the hospital is not able to address all the needs for this individual. So there was revolving doors, a lot of cyclic hospitalizations that were taking place. So cycles of treatment were taking place, but no transformations were taking place. Really, what we needed was street psychiatry was the missing link in this space. And that's one of the things the home team did for the Department of Mental Health. We built a model that was built on the foundation of the ACT model, the assisted community treatment model, but we took it to the next level. How did we do that? We integrated outreach, street-based psychiatric treatment, and housing services the department had. We took all of the resources the department had and brought it curbside to our clients. And not only were we providing psychiatric treatment, we actually were providing street psychiatry with clinical infrastructure for stabilization. What does that mean? If I am treating somebody with, let's say they have schizophrenia on the street, and through a period of extensive outreach, my team is able to convince them to first even see a psychiatrist. By the way, one thing I should mention is the way our model is structured. It goes in a series of outreach. Phase 1, psychiatric treatment. Phase 2, housing. Phase 3, we're always offering housing, but our folks are so sick that they often can't accept housing right off the bat because they're so impaired. But psychiatry is not on the front end, again, because no one on the streets is usually excited to see a psychiatrist. No one is saying, yes, finally, a psychiatrist. It never happens. Most people run away, and they're pretty fast. So we actually have our outreach staff are the ones that do the initial outreach and engagement, build and establish a bond of trust with the individual, and then loop in the treatment team. But when the psychiatrist comes to the streets, we don't just, and let's say our patient says, hey, you know what, doctor, I do think I might have schizophrenia. I would like to try your treatment. What do you do at that point? Do you give someone a prescription? Do you give them a pill box full of medications? How do you expect this individual who's severely mentally ill, barely struggling to provide their basic needs to comply with treatment on the streets? So we actually realized at some point that we would actually need to hand deliver medications every single day. And that's exactly what we do on the home team. We had to build an entire system where our psychiatrists can order medications through our system. It'll go to one of our partner pharmacies. The partner pharmacies will bubble pack the medications. They will ship them back to our medication room where our nurse will receive the medication, log them into our med room, and hand it to our staff who are going out to do daily outreach. They will hand the medication to the client and observe them, self-administer the medication, and report back to the psychiatrist. This allows us to create a system where we can make sure that our clients are receiving the medications, they're taking the medications, and we can do a safety analysis to figure out how we can advance to long-acting injections for whatever treatment needs they have, and ensure that before we put a long-acting injection in someone, it's actually working. It's working, it's showing benefit. This allowed us to very successfully start stabilizing folks on the street. And once they are once their mental health symptoms start improving, once their insight starts improving, once their judgment starts to improve, then we bring all of the resources for housing that the Department of Mental Health has. And mind you, once we place them into housing, we continue being their treatment provider. There is a supervision of long-term recovery that the home team is providing. And only once someone is stably housed in as much of a permanent situation as we can have. Only then do we hand it off to the rest of the DMH ecosystem so they can continue with this individual's care, managing their recovery, and then we focus on the next person. One thing that we do is, while that's the entire outpatient spectrum of services, we are also integrated with acute care. We are also integrated with correctional health, and we are also integrated with the mental health court system. I'll talk about that in a little bit, but what that means is with all of these partnerships across all of these different levels of care, specialty mental health is now operating in an ecosystem of care with clinical relationships across the board. These relationships are what allow us to do what I call large-scale system navigation for our folks, because they need every single service that the entire system has needs to be activated, and it needs to be activated in a synchronous way so we can integrate all the interventions and have a shared vision for what recovery needs to look like. One of the things that the home team is also able to do, and it's very important in this population, and that is the ability to start outpatient conservatorship. We are also a highly enriched, I'll talk about that in a little bit, we are also a highly enriched training site, which means that we have street psychiatry rotations with multiple UCLA and UCLA affiliated residency programs, which means we're not just doing the work, we are training the future workforce of psychiatrists that are coming out. We've actually, most of the staff that on a lot of the field teams where street psychiatry is being provided are former residents. We've been able to show people that this is an important line of work. We have a working model, and we've been able to hire people. There's a hunger for the new generation of psychiatrists to be a force for change in this space. I know I mentioned hospitalizations, but I wanted to mention we have redefined how psychiatric hospitalizations take place in specialty mental health. And the way it works is we actually first have a psychiatrist trying to avoid a hospitalization for our folks by providing robust intensive treatments. If that doesn't work, only then do we do an evaluation that is MD driven to figure out, okay, if a 5150 or an involuntary mental health hold is needed. If it is needed, our doctors will reserve a bed at an inpatient facility, and our partnerships with inpatient facilities are very, very strong. They actually let us know when they have open inpatient beds because they value the transformative collaboration that takes place in this space. Our MDs will reserve an inpatient bed. We will complete the hold in the field, and then we will admit the individual into the identified facility. And we won't hand off care and just wait for the individual to come out. We will show up in the inpatient unit. We will bring our client flowers. We'll bring them clothes. We'll bring them magazines. We will try and make this difficult process as smooth as possible and address the underlying issues that prevented recovery in the community at the point of discharge. So the hospital then becomes a piece of a larger vision of recovery rather than an endpoint in itself. And which is why on our team, on the home team, our return to street rate following admissions is less than 10%. 90% of our folks are housed at the time of discharge, so they have a safe place to land and truly work on recovery. We have also been able to reduce rehospitalization rates by 50% by using this integrated approach. At the very end, so if our street treatment doesn't work, we have integrated hospitalizations, coordinated acute care that we can provide. If that doesn't work, then we have our final intervention, which is a serious intervention. We take it very seriously. We use it sparingly, which is outpatient conservatorship. Traditionally, all conservatorships take place in inpatient psych facilities. These are time-consuming, uncoordinated, restricted, potentially traumatic for the individual, and they involve really long, extended stays while we try and and most of them end up going into a locked setting whenever conservatorship takes place. Our outpatient conservatorship or OPC proceedings are completed in an outpatient setting to the greatest extent possible. Our folks might be, but it does take 3 to 4 months to complete this process, and our folks are pretty sick, which means they might need to go inpatient temporarily, but they don't need to stay there. Once their stabilization is complete, we can pull them out and go maintain the conservatorship as outpatient as possible, which is a lot more reflective of we're meeting the patient where they are at than the traditional process. We also try to put people in open placements. Conservatorship is not about putting people in locked settings. Conservatorship is about ensuring that treatment and supervision is met. That doesn't necessarily have to be in a locked setting. We actually try and put people in open settings first and see if we can, with the right support, keep people in community-based settings rather than locked environments. That's what the model home team looks like across the board. But the best part is next, which is I've done enough talking. Let me kind of show you what our successes look like. A picture is always worth 1,000 words. This is, and by the way, I have consent from all of my clients to share these recovery stories. This is somebody we met. It wasn't even our client. We came across this person while we were trying to find another client. We were unable to this person was too impaired, too frail, too sick to accept any sort of voluntary services. We actually had to hospitalize this person, but we collaborated with the hospital to get this person off the street. This is them being stabilized in the hospital. This is us picking up the individual from the hospital and then transporting them to a CRTP, a crisis residential treatment facility, where they stayed for a couple of months. From there, we moved them into an interim housing facility because they really got everything. They responded really well to treatment and were willing to live independently in their own apartment. And then we helped them get their own apartment afterwards. This journey started out on the street. And now this person is not only in their own apartment, but is employed. I believe they got a job at one of a local fast food restaurant, really reclaimed their life. This next individual never went to the hospital. This case is truly, truly touching to me. It came very close to my heart. This is one of the first people I ever treated on Skid Row. This person was too sick, was moving from one county to another, was bouncing between one county to another in a psychotic state, never really truly managing to stay in one place to receive the treatment and housing that he needed. Eventually, we started treatment on this individual. We convinced them that they needed to go indoors after that treatment started. Once that treatment was on board, we moved them into an interim housing site where we consulted with street medicine, who then came and began co-supporting us on this case. From there, we moved them into an open residential setting with a lot of services, groups, and support. And from there, they stayed there for 1 year. After that, they moved into a board-in care. This picture, by the way, these pictures were taken 4 years ago. This was taken about 4 months ago. And while this person was with us, they revealed that they had a sister that they would like for us to contact. We contacted the sister. Turns out that his entire family thought that he was dead for 30 years. We were able to reunite this individual with his family at the end. And I think the reason why we're here, this is what we want. We want people to reintegrate with the community, reintegrate with their families, and find meaning and purpose in life. With that, I will pass it on to our next speaker, which is Kelly.
Oh my gosh. So Kelly just made it back on the screen in like the most appropriate time. My entire computer decided to go down and it just went back on. So thank you. Well, in the interest of time, I'm not going to spend too much time because I think that Timothy and Shay really was able to share with you, I think, some just incredible on the street stories, which I think is much more important and much more exciting than the health plan's perspective, but I will take about 5 minutes to share that with you. My name is Kelly Bruno-Nelson. I'm the Executive Director of Medi-Cal and CalAIM for CalOptima Health. But more importantly, I'm a social worker to the core and feel so strongly and so passionately about the street medicine program that CalOptima Health has had the privilege of operationalizing in Orange County. We see street medicine is not just something that's nice, but something that are optional, but something that is absolutely necessary. We see it as a means by which to provide healthcare through an equity lens, recognizing that not every individual receives their care or should receive their care in the same way. And that is how street medicine really helps to meet that need for our members that are unsheltered and unhoused in Orange County. There were a couple of components that we looked at when we designed our program. The first is that we needed to look at it from the lens of Orange County. I like to say and believe very wholeheartedly, Orange County is a very special county. We think very highly of ourselves, and we do things a little bit differently. We have 34 cities that really act independently. And so when we designed a program, we needed to do that with that in mind, or our program would not be successful. We also wanted to design the program in a way that was whole person approach, that was not just medical, but included social and behavioral, which of course is the key of our comments today. We also wanted to make sure we created it in a way that was sustainable. So we designed a program that really revolved around a patient panel of 200 individuals that included sustainable and reimbursable services like ECM, housing navigation, the medical services, and also the behavioral health services, which are services that the team can reimburse for. And then finally, we wanted to make sure that our program was evidence-based, that it was grounded in trauma-informed care and harm reduction philosophies, so that we knew that what we were doing was reflective of what we know works best with the folks that we have been so privileged to serve. So what does this look like in Orange County? Currently, we have 4 programs in the city of Santa Ana, Garden Grove, Costa Mesa, and Anaheim. And soon to have a collaborative, which I'm just going to say, take 30 seconds to speak about, because if you took to heart what I said in the beginning of these 5 minutes, you'll see that Orange County does not necessarily play well with others when it comes to the cities. Yet we've gotten to the point right now that we have a collaborative of cities that will be applying to work together to share philosophies and resources to help our unhoused population. That is huge progress for the County of Orange. So we're excited to be able to softly but strongly really impact public policy in our little Orange County world. We make sure that every team has just that, has a physician's assistant or a nurse practitioner, has housing navigators that operationalize with 1 to 25 trauma-informed ratios, and that also has a behavioral health specialist. And that is an important piece of the model, because not only is it a part of that whole person care approach that I spoke about, it's also a part of the sustainability. I think one of the things that's important to recognize, and Brett mentioned in the very beginning of this call, was really the misunderstanding that folks, that health plans, for example, do not reimburse for particular individuals on the street if they have particular diagnoses or things of that nature. That is absolutely not the case. In fact, every one of our 4 street medicine teams, their behavioral health specialist is credentialed with CalOptima Health, and they are encouraged and actually required to bill us for the behavioral health services that they provide. It's part of the sustainability model. So just because somebody has a diagnosis, for example, of schizophrenia, does not mean that that person is not capable of billing CalOptima Health for that service. Schizophrenia is not automatically a carved out service. It could be mild to moderate. So I think that's very important for folks to hear, that behavioral health is on a continuum, and Medi-Cal health plans are required to bill for that. And the model that we've created really accounts for that and accounts for that. So I wanted to, if I can, in the last couple minutes that I have, to see if I can, if my screen is still up. It may not be. Oh, it is. Great. To share something with you. Please let me know if you're able to see that. Hopefully you can. This is our, what we call care traffic control. And we look at and we monitor all of these things within our program to ensure that the program is operationalizing well. And what you can see here are things that we find to be important for them. And then I'm going to skip to the next page. One is we want to know how many individuals are in the program. On the far right, we want to know how many of them have a PCP or an active primary care physician. We allow our primary care physicians for all of our street medicines to be primary care physicians for CalOptima Health. We've gotten rid of that barrier so they can bill directly. On the far bottom left-hand side, you'll see how many of those individuals are enrolled in CalAIM services. Again, this is part of our sustainability plan. So we want to be measuring that to make sure that the vast majority of folks in our plan or in our program are indeed enrolled in ECM and or housing navigation. And then we also measure how many of those folks ultimately get housed, either in an interim or temporary setting, as well as permanent housing. It's very hard to see, but you can see a nice little 47 there. It's a number we're very, very proud of, that 47 folks that are in our program are now permanently housed. This is one of my favorite things to talk about, because these are folks that the system has said are not houseable, that don't want to be housed, that can't be helped, but yet here they are in permanent housing. And I'm hoping that I can scroll down on this. We'll see if it allows me to. Here we go. This is something next that we have now added. If it lets me go down, here we go. And these are the next 4 things that we are measuring that I think are appropriate for today. We measure peer navigator compliance. What that means is, has folks that have gone into the hospital been seen by, peer navigator compliance is, are they seen every 14 days? We require that our peer navigators have a face-to-face with every member every 14 days. On the far right is medical care team compliance. We want to ensure that our medical team is also seeing that individual every 60 days. On the bottom left-hand column is post-hospitalization compliance. This is to ensure that every member that's in our program, if they experience a hospitalization, is seen by their provider within 30 days. That is a HEDIS measure. It's something that is that helps the health plan. It's something that we are measured by, and we want to make sure that our teams are also complying with that. But the most important one for today is this screening compliance. And you can see on that bottom right-hand corner that we are requiring all of our teams to screen our members in SUD, hypertension, and behavioral health, and then refer them to the services that they need at that point. This shows you the compliance for that screening. And I show you that to demonstrate to you that behavioral health is not an ancillary part of this program, that it is a very important piece. It's not only a piece of the whole person care that's provided, it's a piece of the sustainability. So it is absolutely embedded in our program. And knowing that we only have 9 minutes left, I want to pass it off to Lisa.
Thank you, Kelly. See, can we bring up my slides, Caitlin?
Yeah, absolutely. Just give me
Thank
1
you.
second.
So I'm Lisa Long, the Director of Mental Health for LA County. As director, I still go out with our street teams, and it's one of my favorite things to do. I started my career actually, I spent 23 years working on Skid Row, where our clinic operated as one big street team. We were really a clinic without walls, and there was like not a differentiation between being an outpatient clinic and being on the street. And it was such a wonderful way to serve the needs of people where they were and with whatever it was they needed. The one huge disappointment, though, was that it was not sustainable at that time. There wasn't a fiscal way to sustain this kind of practice that we knew was so important to serve people who are unhoused. And as you know, the number of people unhoused in LA County has exploded. It has become more critical than ever to see how we can build partnerships that make this practice sustainable and scalable. So I'm going to talk a little bit about building county partnerships. Next slide, please. So what can we do to partner street medicine and county partnerships? Well, let me tell you first that when I met Brett first, I was so excited because I thought that we in our street teams were alone in all of this. And to know that there was somebody else out there doing this work and really having a passion for it and having something else to offer, you know, and really focusing on a lot of the primary care needs, it really gave me a lot of hope for how we can all come together and build a stronger system to work with all of our unhoused neighbors. So some of the opportunities we see are, I think, first of all, cross-training, right? We all have a huge investment in training up our staff, but sometimes like Shai's team might get a certain kind of training, Tim's team might get a certain kind of training, Brett's team might, and to be able to pull that together and reduce those redundancies and strengthen not just the ability to have training across the spectrum, but to build those relationships as our people get to know each other and train side by side. I think that's a huge opportunity for street medicine and county partnerships. I think consultation, and I think this is something that especially Shayan and Brett have done really beautifully, you know, where they get consultation bidirectionally, and that helps build the capacity for both types of teams. And then collaboration. And I know firsthand, you know, still like going out to San Gabriel Riverbed, working with clients, oftentimes it takes more than one team. Sometimes this is something that's long term. It's not like a one-shot deal where you meet an individual and you treat them and your work is done. This is building a relationship over time. And sometimes one team is effective for a while and you got to hand it off to somebody else or bring in someone else, and having multiple perspectives and multiple touches on someone is so much more effective. So that collaboration is key. And then I think, which is a very exciting development, is our county contracted programs, where we can actually contract with street teams who want to do some of our programs that we offer. And for instance, we have FSP-ICM and ACT and FACT. And I know those are just acronyms to some people, but I'll get more into those a little later. Next slide, please. Okay, so for those of you who may not be aware, which I think most people in California are, we have the Behavioral Health Services Act, which kicks in on July 1st of this year. And what that does for us is it brings in some new opportunities, new challenges too, but new opportunities to be able to expand what we do for our highest acuity clients. Next slide. So one of the things I get asked a lot about is, what about people who have substance use disorder only? And this is something that Behavioral Health Services Act really tried to address. And I think this is very important, especially for our teams that work on the streets, because there's such a high rate of comorbidity, right, with substance use disorders. So BHSA requires co-occurring capabilities in FSP programs and includes the following services: assertive field-based initiation for substance use disorder treatment services, rapid access to MAT, medication for addiction treatment. And I believe all of Shai's teams have MAT capability already, in addition to all our outpatient programs. And then provide support for open access clinics. Now, at first, SUD was a mandated FSP program, but I think as different county organizations sort of transitioned into BHSA, it was decided that this would be opt-in as long as SUD only could be served within FSP programs. So I think at some point as we build this, it will get to a point where we have SUD only FSPs, but for right now, it's a part of the FSP program. So BHSA gives counties that option to expand the use of funds to SUD only populations, including FSP. We're focused right now in LA County on strengthening our co-occurring capabilities. We've always worked with co-occurring clients. We've had treatments for them, but we really want to raise the standard of training and standard of care for our co-occurring clients. And we're also funding SUD-only behavioral health bridge housing with BHSA housing funds, and using BHSA funds for clinicians who will be in SUD residential settings. And this is done through an innovations project. Okay, next slide, please. So what is FSP, Full Service Partnership? Well, currently under MHSA, it's an intensive field-based program and provides our highest level of outpatient care in the Department of Mental Health. This is for people who have had a very tough time in our systems and aren't functioning at the levels that they should be, or that they have been able to with just outpatient care. The aim is really to help those people enrolled function at optimal levels, decrease homelessness, decrease incarcerations, reduce unnecessary medical, psychiatric urgent care, and ER visits. And FSP services provide multidisciplinary care through a team approach, and they also deliver field-based clinical and case management services. In fact, most of their time is spent in doing field-based care. And the services include mental health rehab, therapy, peer services, psychiatry, housing support and navigation, employment, education, benefits establishment, co-occurring disorders, and linkage to healthcare services. Next slide, please. So this is going to change a little bit with the implementation of BHSA on July 1st. And there are the biggest change is really that FSP is going to kind of be split into two categories. At the highest level will be ACT and FACT. ACT is the Assertive Community Treatment Service, and FACT is Forensic Community Treatment Services. And then the lower level FSP will be Full Service Partnership, ICM, or Intensive Case Management Services. So I'll let you read, some of the details on your own. I know that we're short on time, but the focus hasn't changed, though, that we are still looking at providing 24/7 care with a multidisciplinary team for those folks with highest acuity needs. Next slide, please. Okay, and this chart goes a little bit more into what is FSP and ACT versus FSP ICM. You can kind of look at this at your leisure later. Next slide, please. And we go to the last slide. So how do we scale behavioral health care on the street? Brett has said this, Tim, and I think probably Shy. Everybody agrees that we have more clients than any one person can handle. At the Department of Mental Health, last year, we had 250,000 unique clients that we served. So we certainly need the help to, justify these partnerships. We have to really build on our current practices. We have to get our heads together and talk about what really works for our clients. We have to reduce those redundancies. We don't need all of us doing the same thing and crossing over. We have to take advantage of mutual training opportunities. And then I think very importantly, leveraging our funding opportunities. And this is where like county contracting, for instance, really comes in to be able to make these street teams fiscally sustainable. We know it's a practice that works. We know it's super important. And we want to see them grow and go on. And I think most importantly is that, whether you have county care, whether you have psychiatry on the street medicine, whatever the approach is, we want to focus on the fact that we are working with a human being, a full, whole human being. And I just love this quote from Carl Jung. I'm a psychologist by training and Jungian. And he said, a personality, a life history, a pattern of hopes and desires lie behind the psychosis. The fault is ours if we do not understand them. So I think it really is on us to pull together whatever we can to best serve these clients and to collaborate, partner, to do this in the best and most sustainable way possible. Thank you.
Beautiful. Thank you so much, Lisa. That was just wonderful. I'm going to wrap us out here with a few recommendations from a recent report that we did at the California Street Medicine Collaborative. I'm just going to share my screen. Give me a second. There we go. Okay. My name's Caitlin Schwan. I lead the California Street Medicine Collaborative, which is the statewide voice for street medicine. And earlier this year, we got to partner with the California Healthcare Foundation to do a report on, from the perspective of street medicine, where are there huge opportunities for scaling behavioral health on the street. So in the interest of time, I'm going to do this very quickly. My colleagues have spoken so beautifully about this. First up, we feel like very foundational to this work is really expanding clinical contracts for street medicine with managed care plans. So one of the things that we know through a recent study we did across the state is that about 57% of street medicine teams across California have a clinical contract, which is wonderful. There's major growth there, but it also means that 43% of street medicine teams want one and haven't been able to get one. So as we move forward, the sustainability of this work for street medicine is really going to depend on those clinical contracts. The second piece here, and Dr. Wong spoke to this really beautifully, so I won't belabor it, but just there's huge opportunities for partnerships between counties and street medicine that can look like a whole bunch of different things, but certainly shared case conferencing, SMI protocols, working together on a field-based FSP and ACT teams. There's just huge opportunities in this space, and it was really wonderful to have counties and MCPs here in this conversation today. Foundational to all of this, as you folks know, is really investing in the workforce. And again, Dr. Wong spoke to this, but we see huge opportunities with HCI, with BH Connect, to be building kind of field-specific behavioral health workforce initiatives, and specifically to highlighting the role of folks with lived expertise in this work. That's been something that is just so powerful in street medicine and really needs to be at the heart of this work as well going forward. Part of the conversation that we've had today, I think, has really highlighted this, but I just wanted to flag that it's very important that street medicine's kind of part of a lot of the regional planning that's happening. So whether that's county mental health plan meetings or community health assessment and CHIP meetings, making sure that street medicine is part of that regional planning process can help us build the kind of infrastructure we know that will help this behavioral health work on the street. And last up, I know all of us are thinking about this and kind of the moment we're in around the threats with HR1. Street medicine is in a really, really good position to be able to identify and eligibilize folks who are going to roll off Medi-Cal. So there's just very big opportunities, I think, for state agencies, for plans, for counties to be working with street medicine to make sure folks are getting, for example, behavioral health exemptions from the work requirements under HR1, and just ensuring that folks continue to be insured and to do this critical work. So with that, I will stop, and I'm going to kind of open it up here. We have a few minutes for a Q&A. My wonderful colleague Emily put in the chat the link to the report that we did on behavioral health and street medicine. So if you haven't seen that, really encourage you to have a look. But I'm just going to pull up the questions that we've had so far. We have one here from Kate. Due to the complexity of the patient served, how do you account for this in your contracted fees and PPS rates, specifically when it comes to behavioral health services? So maybe that would go to Tim and Shai.
Shai, feel free to take a stab. I kind of put my thoughts in the chat. So
Oh, you did. Great.
yeah, hopefully you can see it.
Perfect. Shai, do you have anything to add on that one?
Well, when it comes to our contracts, that would be more Dr. Wong's thing. For most of the services we provide I'll be honest, a lot of the services that we have to provide sometimes are non-billable because we are doing care coordination when there's Medi-Cal lockouts, and we have to go in and supervise these transitions of care. You know, I'm directly operated. I'm not a contracted provider, so I have the privilege of Dr. Wong's forgiveness for when I'm providing services that are not covered. But it raises a very good question. Like, you know, there's a lot of redundancies. There are a lot of things that are not reimbursable, and there needs to be a little bit of imagination around how we kind of fund transitions of care where traditional funding doesn't work, so that way the quality of care can be preserved. That would be my sense. I don't know how we factor that into contracts, because it will require a lot of restructuring, but new funding streams that allow us to do that would be a good direction to go.
Well, I think contracting for specialty programs like FSP try to take into account the acuity level of clients. And that's why we thought FSP was such a great fit for street teams, because one of the focal populations is people who are unhoused. And I think, you know, of course, the rate that the state thinks encompasses everything we need is typically not sufficient. So it behooves us then to be really good record keepers and really mindful of the data to show like what it is we actually do, what the actual cost is it is to us, so that I can take that information to the state and say, hey, I need more money for these services.
Yeah, if I could, go ahead, Tim. Go ahead.
All I was going to say is apologies. I'm realizing that the messages I sent, the attendees can't see. So I get all I really said in response to that question was that when we do contract with managed care organizations, which we do directly, we sort of encapsulate the complexity of the population that we serve in the ways that the managed care organization wants to hear that, and sort of to the best of our ability and the different aspects that they're sort of focused on. And we work out an appropriate rate for those services. I mean, I think it's essentially contracting based on exactly the point that you've made, Kate. So, Brett, I'll leave it to you.
Oh, I just wanted to clarify for everyone, if you're not aware, there's two different streams of contracting. One, if you're not a county mental health, and speaking as a street medicine provider, primary care street medicine provider, you'll have your managed care contracts, and for them, and you can bill mild to moderate under those managed care contracts. For them, it's important to understand the level of complexity that you're dealing with. And if you're interested to learn more about that, we can talk offline. And then there's your county contracts, which is a different funding stream. And what I like about, because we're interested in doing a field-based FSP team, what I like about those is that it's pretty prescriptive from the state. It tells you there's some flexibility in how you staff the team, but there are things that have to be on the team. And then they even publish the rates so you can get a sense of it. Now, what's not billable is you only get paid for the people enrolled in your program. All that time that is spent outreaching and building that relationship and all that, that's not reimbursable. So it'd be great if it was, but the idea is you have to enroll people in
Well,
order to pay.
a certain amount is of the outreach and engagement is able to be captured. I think the first 30 days of it or something. So I think, that is partially it, but, I myself have taken months and months of trying to engage somebody. And then we also have something called presumptive consent now, too, for enrollment with FSP, which hopefully, Brett, will make it easier for field teams.
Yeah, I think I'm talking definitely. I think I'm talking about like all the people that we talk to on a daily basis that sometimes you don't even know, like you get their name after a few visits and but you spent time doing that.
Okay, wonderful. We have a great question in the Q&A here from Kiana. Thinking about your various funding streams, you mentioned Medi-Cal and CalAIM waivers, which seem critical for sustainability and scaling of your services. Are there concerns about federal Medicaid cuts and eligibility changes affecting these street medicine programs?
Yes, pretty significantly.
Yes.
If I could just outline HR1 for a second, and I'll try and be quick for everybody. So they have this community engagement requirement, which is essentially a work requirement. If we know that over 90% of the people are not engaged with care, then and people are not going to be able to work. But there are these uh, exemptions that they'll most likely qualify for, like medical frailty, substance use disorder, mental health disorder. In order to get those exemptions, they have to see a provider that can certify they have the exemption. If over 90% are not engaged, then they can't get the exemption and they would drop off of coverage. So that's the big role street medicine is going to play, is engaging the folks, qualifying them for the exemptions.
And, we're currently advocating with the state right now to make that proof of exemption as low barrier as possible. So that let's say Brett is starting to see somebody on his field team and they have like one encounter that would be in the system already and already, say that this person is exempt. We haven't gotten that all the way through yet, but that's what we're hoping for.
Wonderful. Shy?
I can just mention as the Department of Mental Health, we routinely serve people who are uninsured, don't have any sort of benefits. So we do have some mechanisms in place to activate temporary benefits where we can kind of cover some of their medications. Of course, if it's going to look like that someone's coverage might not be in place, I'll probably be circling back to Dr. Wong to see if we can kind of expand those options available.
Yeah, we're back to that forgiveness thing again, right, Shai?
Yeah, it's a habit of mine. To try
And the direct question on it seemed like there was a center on the CalAIM waivers, which I think for Healthcare in Action is so, proportional to our sustainability as an organization. And so, yes, I mean, I think that the sort of existential threat on the federal lens sometimes it makes us think twice about how CalAIM will look as it kind of reaches a sunset point towards the end of this year, at the end of this year, and into next year, but at the same time, kind of engaging with our state partners and learning more about how CalAIM will look going forward. It seems that we have some assurances in place that at least in part we'll be able to continue those services. And so yes, it's a concern and also a point of sort of improvement going forward.
I think another thing that we have to consider about the impact of HR1 is that, right now, mild to moderate folks have coverage. They will not have the work requirement exemption. And as they lose coverage and lose access to care, we predict that many of these people will become much higher acuity and become SMI. So, that is a really big concern to take into consideration.
Well, folks, we've hit time here. This was such a pleasure. Thank you all so much for being here with us. Thank you to our panelists. This work was sponsored by the California Healthcare Foundation, who's just been such a champion for behavioral health on the street. So thank you deeply for your support and so much solidarity and care to all of you who are doing this work. Really, really important time for the field. So thank you all. I hope you all have a great afternoon.
Everybody.
Thanks, everyone.